And I'm going to make you the host. There you are, Doc. So whenever you're ready, you can share your screen and kick things off.
Let's see. Well, thank you all for spending time with me tonight. Let me go ahead and start.
Your microphone is a little faint, so just speak up a little bit.
Oh, okay. Is that better?
That's much better, and we can see your presentation. Looks great.
Okay. I wanted to tell you both the general experience as well as my personal experience with treating Alzheimer's and other degenerative diseases, starting with where we were. When I first started, there was no treatment back in 1988. And then where we are now, and then where we're going. This is a summary of the history of the various proposed causes of Alzheimer's and the treatments that developed. Starting in 1907, when Alois Alzheimer described plaques and tangles and was given the distinction of the disease being named after him. It was another 70 years before a hypothesis other than hardening of the arteries was proposed. And in 1976, the idea that loss of a brain transmitter, acetylcholine, was the cause. Now, it took approximately 20 years to develop treatment for raising the transmitter in the brain, acetylcholine. A series of transmitters were developed, the most famous of which is donepezil or Aricept, and we'll have some comments on that. In 1984, the amyloid hypothesis was proposed, namely that amyloid is a protein that can misfold and initiate a trigger of events that leads to the development of Alzheimer's disease. It took approximately 25 to 30 years to develop treatments that actually bind to amyloid structures and remove them. Now, I will go into a little bit more detail about amyloid because unlike the way the literature presents, amyloid is not a single structure. And this ends up being a critical point and has potentially been a reason that effective treatments have been less than forthcoming. The treatments that have developed over approximately 12 to 13 years all consist of antibodies that bind to different shapes of the amyloid structure. In 1992, another hypothesis developed that a particular receptor that's involved in learning and memory was key to the development of Alzheimer's disease because of the way it influenced the influx of the ion calcium into the cell, which would then trigger changes that led to Alzheimer's disease. Only one treatment developed out of this approximately 10 years later, which is memantine, which continues to be useful today. In 1997, the idea that cells can undergo stress, and this stress leads to damage to proteins in the cell, which then must be repaired by having the cell generate new protein to replace the damaged protein. And this led to the use of intravenous IgG, an antibody that is not just a single type of antibody, but consists of many different types of antibodies against many different types of misfolded proteins. And in 2016, the intravenous route was replaced by an intranasal route, which is to inhale these antibodies through the nose. In 2023, that's now, this is where I think, well, this is where I'm going. I don't know where anybody else is going, but I'm going there. It'll be the use of Tempol as well as antibodies that are specific to each patient's disease. Ending up in 2009 with the hypothesis that one of the misfolded proteins of Alzheimer's called tau, better known as tangles, led to the development of Alzheimer's disease, and a treatment called LMTM was developed approximately 9 years later and is currently in a phase 3 FDA trial. So that gives you a kind of a timeline of how things are developed. And the big point here, and this is very important, I think, each of these hypotheses defined what they thought was the cause of a disease. Now that then restricted what drug treatments were developed. So if the cause of a disease is not close to being accurate or correct, it will lead to the development of treatments that are not effective. So where we were in 1995 was the advent of the cholinesterase inhibitors, as I mentioned, the most famous of which is Aricept or donepezil. I also put asterisks next to ribostigmine, also called Exelon and galantamine, because it turns out that they do have ability to block the production of the misfolded proteins that are involved in Alzheimer's disease, where donepezil does not. This picture shows two important studies, the first of which was in 2008 by Ali Atri at the Harvard Memory Program, where he studied patients for 4 years who had Alzheimer's of varying severities. And without going into a lot of the detail, what they found was that for every level of severity, Aricept, the effect of Aricept, was exactly the same as not treating the patient at all. Regrettably, the majority of physicians in the United States still prescribe Aricept, even though it has no treatment effect. Quite surprisingly, 2 years later, the makers of the distributors of Aricept, Pfizer Corporation, they published a paper by their global research team that showed that Aricept or donepezil was exactly the same as placebo after 6 months of treatment. For the first 6 months, there was some improvement in symptoms, but after that, it was completely ineffective. And I always wondered why Pfizer would publish this and take out one of their own treatments from action. The story is that there was another treatment they were going to introduce that they thought would be FDA approved, and it did not get approved. So they had a bit of a premature blunder. Where are we now? Well, right now we use things that do in fact delay the progression of the disease, even though you will not hear that very often. That includes neurotransmitter treatment with memantine And one of the cholinesterase inhibitors, I prefer ribostigmine and galantamine because they do have a treatment effect that blocks misfolded protein production. We also have the advent of monoclonal antibodies to treat AD, which remove a single type of misfolded protein. This is why they're called monoclonal, a single clone of antibodies that target a single type or shape of misfolded protein. Going back again to the same study by Alia Tree, what we see is the blue curves show patients with Alzheimer's with different severities at the starting gate. And in every case, the combination of amantine and either ribostigmine or galantamine, or in those days, they certainly used Aricept a lot, but that combination delayed the progression of Alzheimer's disease in terms of the functional decline, which matters to people, by anywhere from 33 to 60%. Furthermore, it typically would improve memory and other cognitive abilities for at least 2 to 3 years before those abilities came back to their baseline values. There are reasons that these functional delays occur, and it is known, for example, that memantine blocks an enzyme that is involved in producing tangles. It is also known that the cholinesterase inhibitors, and in specific ribostigmine and galantamine, they block the production of the beta amyloid, which is proposed to be the first misfolded protein to develop in Alzheimer's. The amyloid hypothesis was first proposed by George Blenner in 1984, and subsequently the treatments that developed to treat the amyloid that accumulated consisted of these monoclonal antibodies, also called IgG. And there was a string of failed clinical trials: bapineuzumab, solanezumab, crenezumab, gantenerumab. Finally, in 2022, aducanumab was approved after a tremendous amount of scientific controversy. However, after 1 year on the market, there were enough brain hemorrhages that the approval was withdrawn and aducanumab was taken off the market. Well, just last month, the FDA approved a newer monoclonal antibody that binds to some forms of beta amyloid. This is called lecanemab. The clinical effects were considered marginal. It does lower levels of amyloid in the brain. It does not stop the progression of tangles if they are present. The company that makes lecanemab proposed that they will charge $26,000 a year, but it also has to be administered intravenously, and there are, of course, costs for the infusion service. Lecanemab has a lower risk of brain hemorrhage, but it is still 12%. Not all brain hemorrhages are considered symptomatic or serious, but a single brain hemorrhage that is serious would wipe out any benefit of this treatment. Now, I want to provide a little bit of a perspective on amyloid because it's not a single shape. It starts out as a single strand of peptides or protein called a monomer, and then it aggregates with other protein monomers to form aggregates. And these aggregates can take on many different shapes. Now, keep in mind that each of these different shaped structures have different toxicities to the neuron And each of these structures is bound by only one type of antibody. So a single antibody does not bind all these shapes, it binds only one of them. That's very important to keep in mind. Where was I in 2018 to 2015? Well, in addition to the combination of memantine and my preferences would be ribostigmine and galantamine, I began to use intravenous human polyclonal IgG, following the lead of Norman Relkin at Cornell University, who did conduct an FDA trial of this same treatment. The differences between the FDA trial and what I did were predominantly the duration of treatment. The human polyclonal IgG is commercially available and has in fact been used for over 50 years for many, many different types of disorders. The polyclonal means that there are different groups of antibodies that bind to different shapes of misfolded proteins. And these antibodies are produced by aggregating thousands and thousands of blood donors, each with their own pool of antibodies that have developed against all the various invasions into their body that have accrued over their lifetime. Any misfolded protein that is part of a degenerative process, an individual will develop an antibody against if that misfolded protein is present. So what you get is a hodgepodge of many different antibodies against many different misfolded proteins. And that is a very important distinction from a monoclonal antibody. Now, initially, I pursued the route of intravenous administration of the human antibodies because that's what everybody else did. And the results of this were that over a course of treating 17 patients for up to 7 years, the treatment was effective in 4 out of 4 Lewy body disease patients, 10 out of 12 Alzheimer's patients, and 1 out of 1 multi-system atrophy patient. And that was in terms of the delay of progression. It delayed the progression by 200 to 700% relative to the prior course of the individual before receiving this treatment. But the cost was $10,000 a month, and it required an infusion service. So here I saw something that had potential, but was impractical for almost everybody. So in 2014 or 15, I learned that there were studies that showed a mouse could inhale antibodies through the nose, and they would get into the brain up to 30 to 100 times better than through the blood vessels. Since that time, since 2015, I began treating with the antibodies using an intranasal inhaler developed by Curve Technology that is very special in the sense that it makes the droplets of the IgG antibody solution microscopic so they can get into the brain, and then it propels the antibodies up into the nose in a way that it saturates the membrane of the nose to maximize the entry into the brain. And to date, I have treated about 170 patients for up to 8 years. Now, these patients didn't all have Alzheimer's. I've treated up to 8 or 9 degenerative brain diseases. And all but one or two of them have clearly had patients with real improvement, stabilization, or substantially slowed decline. In fact, I think, and I'll be able to prove as a result of a generous donation from one of our families, that that this treatment does in fact alter the progression of the disease, and in some cases it stops it, and in some cases it partially reverses it. The treatment effect can be reliably determined in each patient using a rule that I call all roads have to lead to Rome. In other words, if the MRI, brain imaging, the spinal fluid measures of the misfolded proteins, the cognitive and functional changes are all pointing in the same direction, then I can conclude that this is a real ability to assess a treatment's effect. So intranasal IgG antibodies replaced the intravenous IgG, and I boiled it down to a relatively simple way of looking at it. When we start treatment, we assess the level of the misfolded proteins in the spinal fluid, and then we have a measure at baseline. We also get a picture of the brain, quantify that. We measure cognition and function. And then over a course of several years, we continue to monitor these abilities and finally repeat the values of the spinal fluid and the brain imaging. And that gives us quantitative assessment of the changes due to the disease progression as well as due to the treatment. And as you see on the graph, if the misfolded proteins increase over time, patients almost always show decline. If the misfolded proteins remain stable, as shown in the yellow arrow, then patients remain stable. And if we can lower the misfolded protein levels by 20% or more, we see partial improvement. That's a very, very consistent result. I've only seen several exceptions on that out of 170 plus patients. Okay, well, where am I going? Well, I believe that reducing cell stress and removing misfolded protein aggregates with patient-specific intranasal human polyclonal antibodies, plus a revolutionary new treatment that repairs cells, is the way of the future. And to show you this, I've drawn a picture which involves a brilliant development of an array by Charlie Glabe at UC Irvine. And this array consists of over 500 wells, and each well has a different misfolded protein in it. We then take a sample of a person's blood. A milliliter of blood is perfectly adequate to do this. And we then extract the serum from the blood and expose it to this array. And whatever antibodies an individual has that are targeting a degenerative disease, a particular misfolded protein will bind to one of the wells. And what you see here are 4 of the wells are colored, and that just simply would represent the antibodies that a particular patient has against a particular set of misfolded proteins. And that literally defines the degenerative disease that patient has. Well, once we have done this, we can do several things. We could simply extract those specific antibodies and treat the patient by having them inhale their own antibodies. Or we could get even more precise. We could get some spinal fluid from the patient And then we could again put the spinal fluid on that array and find out which of the misfolded proteins the patient has antibodies against that are in the brain. And then we would extract those and have the patient inhale those. Now, compared to what I can currently do, keep in mind that when I write a prescription for these polyclonal antibodies that are sold by various commercial vendors, such as GammaGuard, Gamunex, Privigen, etc., that only about, and I'm guessing, but somewhere well under 10% of those antibodies are targeting degenerative disease misfolded proteins. It's probably closer to 1 to 2%. Well, if I'm using antibodies derived from the patient themselves, then they will be inhaling 100% of antibodies that are targeting their brain disease. So we should be able to remove anywhere from 30 to 100 times as many of these misfolded proteins compared to what I can currently accomplish. And what I've accomplished now is as good as any clinical trial that I have seen so far. I will finish and then be happy to answer questions with a little bit of background on the newest hypothesis of degenerative disease. And keep in mind that every disorder that we know of that is considered a chronic disorder, if it's not well controlled, it will cause stress to the cells. And the cells, when they are stressed, they have proteins that are damaged. Each cell has about 100,000 proteins. And so whatever ones get damaged must be repaired or replaced. So the cell has a system of repair. And here are two examples of different degrees of cell stress. When the cell is stressed by any common condition, any chronic disease, any trauma, any infection, etc., then proteins are damaged and new proteins have to be made by the cell. That's step one. Then they have to be folded into the proper functional form. That's steps 2 and 3 on the left side. Finally, they have to be packaged and transported to the site of the damaged protein. That's step 4 in the green arrow. And that's how cell repair works when there's intermittent cell stress. However, chronic cell stress, such as diabetes that is not well controlled, or a blood pressure that's not well controlled, or sleep apnea that is not treated, or high cholesterol that is not treated, that's a chronic form of stress. And eventually that overwhelms the cell's capacity to repair itself. And when that occurs, instead of proteins being folded properly, they start to get misfolded. That's the red arrow pointing to the right. And what you see is when any given protein misfolds, it can assume many different shapes, not just a single shape. And so what happens is your immune system will then develop antibodies against the shapes of the misfolded protein aggregates that are formed. And if you can produce enough antibodies and get rid of these misfolded shapes, everything's fine. But eventually, the misfolded shape production outstrips your immune system, and they start to attach to the cell membrane and punch holes in them and kill the cell. And that is the basis of what we think is the cause of all degenerative diseases. So this is a great example that Charlie Glade lent to me. A single patient with a diagnosis of Alzheimer's disease. And when they used his array with 1 milliliter of blood, what they found was this patient had 22 different antibodies against 22 different shapes of misfolded protein. Well, think about that for a moment. Lecanemab, which is the one antibody, is a monoclonal antibody that just got approved. It binds to a few of these different shaped misfolded proteins. Well, that's like if you bind to a few of the misfolded proteins, and let's say 18 more different shapes don't get bound, they continue to proliferate and progress the disease. And this is why I think that the treatment effects of lecanemab and these other monoclonal antibodies are only marginally effective. They're not removing the lion's share of the degenerative disease process. And I found this out actually in doing the spinal fluid testing in the Shankle Clinic patients. This was a number of years ago when we had only done about 557 spinal fluid tests. What we found was that of the 82% of patients who met the spinal fluid biomarker criteria for Alzheimer's, of those 82%, only 6% had just Alzheimer's. The other 76% had Alzheimer's plus other degenerative diseases. What does that mean? What that means is that if a hypothesis that says this is Alzheimer's disease, and that leads to development of treatment for Alzheimer's disease, there are very few patients that actually have just that disease. So giving that treatment is not going to treat the degenerative diseases that are present that are not Alzheimer's disease. What we find is that most patients don't have just Alzheimer's. They have many different types of degenerative disease. And until we treat the different types, all of them, our treatment effects are only going to be marginal. And that's one reason I think that the dilute preparations of the polyclonal IgG that I've been using intranasally has been effective, because it's certainly not as potent as the monoclonals, where 100% of those antibodies are binding to one particular class of shapes. Certainly not effective that way, maybe only 3% bind, but we're binding to all the different shapes that a patient has. And so by removing them, we are getting significant treatment effects that are comparable or better than what I've seen in clinical trials. I think that summarizes where we are. I just mentioned that we have begun working with Matrix Biomedical to develop clinical trials using a remarkable treatment that helps cells repair themselves and survive if they are worthy of surviving, and helps cells die if it's too late for them to survive. And this treatment has been effective for a broad range of chronic diseases, at least in experimental models, as well as in compassionate use cases in humans. There are over 2,500 scientific studies of this molecule, and it covers an incredible range of disorders. We think that it will work for degenerative diseases as well, and we are writing approximately 3 or 4 different clinical trials with the use of this compound plus the patient-specific antibodies in the near future, perhaps within 12 months, as well as starting some treatments sooner than that with these clinical trials. So with that, I'll stop and be happy to answer any questions.
Okay, great. Thank you very much, Doc. And we have several questions. So I'm just going to start from the top here. First one is there any relationship between Alzheimer's and essential tremor? And follow-up is, do you treat ES?
There are patients that there are some studies, there's not a lot of literature on this, but there are some studies that show that cognitive impairment can occur in patients with essential tremor. Essential tremor, it may fall under the category of the so-called synucleinopathies. What does that mean? It means that there is a class of misfolded protein called alpha-synuclein. And the accumulation of alpha-synuclein will cause damage to nerve cells. Depending upon the location of these misfolded proteins, it will produce symptoms related to the function of that location. For example, you can get tremor from damage to an area of the brain called the cerebellum. You can get tremor from an area of the brain called the basal ganglia, and so forth. So if it's worthwhile to evaluate if there is a misfolded protein disorder that could be treated in persons with essential tremor. It may not be anything related to Alzheimer's, however.
Great, thank you.
Mm-hmm.
Next question is, how long does the process take for you to ascertain what is needed for a patient? So I think this, they're getting at just the general diagnosis process.
So in a person who is, we think, has a misfolded protein disorder, we initially do a cognitive assessment and a functional assessment. We then order blood tests to diagnose causes of cognitive impairment and treat them. We also order a picture of the brain called a quantitative MRI that helps us diagnose other causes that we can treat. And then finally, if we suspect a misfolded protein disorder, we then order a spinal fluid test to measure the levels of any existing misfolded proteins and develop a definitive diagnosis of the problem. That whole process will take initially with the quantitative MRI and the blood test, that can be done in several weeks. When we do a spinal fluid test, once that test is done, the laboratories that do them take approximately a month and a half to provide a result. So there's a delay of approximately a month and a half before a diagnosis could be made when there's a spinal fluid. So the whole process could be done within approximately 2 to 3 months and have a definitive diagnosis and a definitive treatment.
Great. Next question, how does memantine work? Does it attack only a single area or is it a more broad treatment?
Memantine is a very interesting treatment. I began studying it before it actually became available in the United States. I got it from Germany, where it was originally manufactured as early as 2003, and began using it in combination with ribostigmine. Memantine is something that binds to a receptor in the brain, and they're all throughout the brain, these receptors. They're called NMDA receptors. These receptors, when you are learning, there is an excitatory transmitter that is released. It's called glutamate. The same thing that you ingest when you get Chinese restaurant syndrome and you get flushing and a headache from monosodium glutamate, or MSG. Well, the major excitatory transmitter in the brain is glutamate, and it is released when you are in the process of learning something new, but it's released in a very specific way. It's released in pulses of about 5 times per second. And when the transmitter arrives in the memory structures of the brain, it binds to this receptor called NMDA. When, again, appropriately stimulated, that receptor, then it causes an influx of calcium, which activates all sorts of processes inside the nerve cell, and it literally changes the shape of the connections from being a mushroom shape with a narrow stalk to a mound like a nub. And that change means that when that particular connection is stimulated, again, after it's made that change in shape, it transfers much more electricity and makes that nerve cell receiving the signal much more likely to generate an electrical discharge. And so by making it easier, that is what we mean when we say we remember something or we've learned something. It's easier to recall that once you have learned it, and that learning involves a change in the physical structure of the connections that store memory and help you retrieve them. And so memantine facilitates that process. And that is why you can often see very significant improvement in learning and memory if there is a deficit in either the transmitter or the amount of these receptors that are present.
Great. Thank you. The next first, we just have some excitement about the customized treatment approach. So thank you for submitting your thoughts there. And the follow-up is, what are the statistics on brain degenerative disease rates of growth / decline / change? So I think what this person is getting at is perhaps thinking about patients that you are treating and what percentage of those are in each of those buckets.
Okay. So could you just restate that question one more time?
Yeah, what are the statistics on brain degenerative disease rates of growth, rates of decline, or rates of change?
Okay, I understand. I've been trying to answer that question by careful data analysis for quite a few years, and unfortunately, the electronic healthcare record vendors, they make a great deal of effort to keep you from getting data out of the record so that you can do this type of analysis. Fortunately, just recently, we received a generous donation that has allowed us to put together a team to actually extract the data. And we've finally had a success in extracting the data so that we can precisely answer that question. What I can tell you qualitatively is that in every patient, when I measure treatment effect after getting a repeat spinal fluid and a quantitative MRI, I look at the changes in the misfolded protein levels. I look at the rates of tissue loss in the brain regions, and I compare those to the changes in cognition, as well as the changes in cognitively mediated function. And by doing that, you get a very clear idea of the effect of any treatment you deliver. Now, as a result of that, I've developed a gestalt impression that probably 75% of the patients who undergo intranasal IBD, plus the additional therapies that have been commonly available, about 75% either stabilize or show partial improvement, and about 20%, which is about 95% total, will show dramatic reduction in the rates of decline, and 5% don't really show a clear treatment effect. That is, I think, there's a lot of variables that we can't necessarily control for, but my sense is that the amount of disease is an important factor, so that the earlier one intervenes, the less disease there is, and the better the treatment response there is. When there's a lot more disease, you have to remove a lot more before you see a significant benefit. Does that address the question?
Yeah, I think it does. And then going kind of one level higher and a quick follow-up, the same person is asking, are the rates of brain disease in the USA increasing? So amongst the general population, what types of trends are we seeing, if you are aware of that?
Well, certainly the awareness of cognitive impairment has gone way, way up. So people do, in fact, come in much sooner than they used to. I remember when we started out, most people would come in when they were moderate to severely demented and could not dress, bathe, use a toilet properly. That was back in the late 1980s, early 1990s. Now what I see is that the majority of patients come in and are still functioning normally. They may have to work harder at compensating by using a calendar more often, or having more structured routine at making sure they don't miss any appointments. That is a stage of function that we all enter at 45 years old, when our memory declines normally with age, and we start to use compensatory processes like using an iPhone or a calendar to keep track of things more often. And as long as we can do that, we can compensate on our own. That is what is called fast stage 2, which is normal function with compensation. The other group of people that I typically will see now are in the next stage, which is classically known as mild cognitive impairment. And this is a stage which is, again, very similar to fast stage 2, but the compensatory mechanisms that they have used, the iPhone, or I don't want to advertise Apple anymore. I'm sick of them. But the compensatory methods that they use are no longer working, so they start missing appointments. And then a spouse or a loved one will start intervening and help with reminders on a regular basis. That is what is called fast stage 3 or mild cognitive impairment, in which there is a functional impairment that is related to a severe enough memory impairment to impair function. And that's the group that I now see most often, the fast stage 2s and the fast stage 3s. Now I'm getting family members who are the children, the adult children, want to know what they can do about prevention. And I'm totally excited about that. I think we have all the tools now we need to prevent these degenerative diseases. And so I'm very excited about the ability to use Charlie Glave's assay and to start working with these newer treatments that offer a tremendous opportunity to stop brain diseases before they impair function.
Okay, great. Thank you. Just so a couple more. I know we're getting close to the hour here. Someone asked, when will patient-specific treatments become available? For instance, using a patient's blood to determine treatment.
We are working right now with Charlie Glave to implement that array. And I'm hoping that within the next 2 or 3 months, we'll be able to start that. I'm always optimistic and people shake their heads, but this is not 12 months away. I think this is much sooner than that.
Great. Okay, let's try and get it one more here. Tau protein, is this very different from the protein for dementia, and how much understanding do you have for PSP?
Yes. So the tau protein is a thread-like protein. It's like a thread. And what it does is it keeps these tubes that run down the branches of a nerve cell. And these tubes are called microtubes. They are literally look like beads on a string. And if you don't have something wrap around it, they fall apart. Well, when that happens, the ability to transport nutrients to the connections on that nerve cell disappears. And so those connections, they die, and the nerve cell tree, it starts to retract because it's losing the branches and the leaves on that tree. So the tau protein is that thread-like protein that wraps around those beads that make the tubes that transport the nutrients to all the connections of a nerve cell. There's approximately 20,000 different connections on a single nerve cell. So you can imagine that if you start to unravel those thread-like proteins, then the ability for that nerve cell to survive goes way, way down. That's very different from the amyloid protein, which is something that is found on the sending side of a connection between two nerve cells, so-called the presynaptic side. That sending side, if it gets amyloid in it, it blocks the release of one connection to one receiving connection. So since we have 20,000 of those on each nerve cell, the impact is 1/20,000th of the impact of blocking a branch of a nerve cell. And there are only 8 branches on a nerve cell. So the impact of tau misfolding is much, much greater than the impact of the amyloid misfolded protein. In progressive supranuclear palsy, multi-system atrophy, corticobasal degeneration, frontal temporal lobe disease, ALS, these are all called tauopathies because one of the misfolded proteins is the tau protein. And that's why it's such a difficult disease, because you knock out neurons much faster than a disease like amyloid accumulation.
Great. Well, that's an hour right there. So I think we'll go ahead and stop it there. But thank you to everyone who typed questions in, and sorry that we didn't get to all of them. perhaps we can figure out a way to follow up on some of these questions or post responses somewhere. So I have taken them down. And we'll try and figure out a way to get those answered. But thank you, Dr. Shankle, and to all of the attendees who tuned in. Thank you very much for joining, and have a great night.
Well, thank you, Connor, for taking time away from your young baby. I appreciate that.
Yes, I think she's down now, so I'm gonna go check. Okay, have a good night.
Okay, good night.
Cheers.